Okay, sige. Let's now talk about your fluid regulation. Okay, dito we will be talking about the homeostasis. Pag sinasabi natin homeostasis, that is basically the balance in our body. Our body, whenever matilt yung ating fluids, no, or matilt yung balance na ating fluid, you will have there fluid volume deficit, or that means pag fluid volume deficit, kulang tayo sa tubig, yung katawan natin kulang sa tubig, or you also have there your fluid volume excess. That means that the fluids inside our body are over sa normal. Kuha natin. So if ever these, or if ever the homeostasis or the fluid balance is being tilted, ito yung mangyayari sa atin, or these are the regulatory mechanisms that would compensate for the tilting or for the imbalance of your fluid. The first one, of course, is your thirst. Nauuhaw ka. Pag dehydrated ka, what do you feel? Nauuhaw ka. You also have there your kidneys, your respiratory system, specifically anong organ sa respiratory system mo? Krr, krr. Anong organ? Hello?
Lungs, sir.
Yes, very good, lungs. Okay, you have there. Yung question is kung ano yung organ that regulates yung ating fluid or homeostasis for fluid regulation. Of course, it is your lungs. Okay? You also have there your RAAS. Anong meaning ng RAAS natin, class?
Renin-angiotensin-aldosterone.
Yes, your renin-angiotensin-aldosterone system. We will be discussing. Lahat ito, i-discuss natin isa-isa. Okay? You also have there your ADH or your antidiuretic hormone. In other books or another term or name for your ADH is what? Vasopressin. Or your vasopressin or vasopressin. Okay. You also have there your atrial natriuretic peptide, and you also have there your cortisol, and you also have there your parathyroid hormone. Okay. We will be discussing kung paano nito nire-regulate yung ating fluid imbalance. Okay. Ayan, let's talk about thirst first, okay? Now, sa thirst natin, this is basically the primary regulator of water intake. Bakit? Kasi if ever you will feel na uhaw ka, that means that there is already an imbalance of your water at kailangan ng tubig ng ating katawan, okay? The thirst center is basically located sa brain. What specific part in your brain? Who can tell me?
Hypothalamus, sir.
Yes, very good. You have there your hypothalamus, okay? So next question is what stimulates your thirst center? Of course, dehydration. Or if mababa na yung ating fluid content sa ating katawan. Okay? That is for normal na tao. Now, meron din kasing your thirst will also be stimulated, let's say for example, in diabetes. Okay? May problema tayo sa diabetes or may problema tayo sa insulin. So, magtataas ngayon yung ating sugar level sa blood. Okay, and the effect of that one, remember yung ating diabetes, you have there 3 P's. Okay, ano ba yung 3 P's ng ating diabetes? You have there your poly, and the third one is poly. Puro poly yan sila, ha? You have there your polydipsia. That means this is excessive thirst. Okay, cellular dehydration or cellular thirst. No? Polydipsia is your excessive thirst. Polyphagia naman is your excessive hunger, and polyuria. Alam nyo na yung class ko ano yung polyuria. What is polyuria again? Frequent urination. Okay? Ayan. So it is very much highly effective in regulating extracellular sodium levels. This is also a basis, another stimulus that stimulates your thirst is of course yung extracellular sodium levels natin. Question, sir, anong levels yan? Mataas o mababa? If your extracellular sodium levels are high, that will now stimulate you to drink water. Pag mababa naman yung ating extracellular sodium, how do you call this, sa ating katawan, okay, you don't, ano tawag ito, you will not be stimulated to drink. Okay, kuha natin yung relationship. Pag mataas yung sodium levels, that means that concentrated masyado yung ating dugo. Kasi nga, this is basically your abundant cation, no, outside of the cell. Kuha natin. So for that to be normalized, kailangan mo uminom ng tubig, no, para mag-normal yung ating levels ng sodium and of course the concentration of your blood. Okay? So a drop in serum sodium or low serum osmolality, ito na yung sinabi ko sa inyo kanina, it inhibits your thirst center. Sir, tanong, ano ulit yung osmolality natin? It talks about, ito lang yung isipin ninyo, class. If ever we're talking about your osmolality or if ever you will be encountering the word osmolality, okay, isipin nyo lang it is the concentration of both your solvent and your solute. Kuha natin. Pag dehydrated ka, what do you think will happen to the serum osmolality? Increase or decrease?
Decrease, sir.
Again, if your serum osmolality
Increase, sir.
yes, of course. Okay? So pag mataas yung serum osmolality natin, that means ano, mataas din ang concentration. Okay, that means that mababa yung solvent. Kaya nga nakalagay dito, a drop in serum or low serum osmolality, you will not be thirsty. No? Pero pag mataas yung serum osmolality natin, that means that mataas yung concentration ng ating solutes, then it will now stimulate your thirst. Kuha natin. Ayan. So if what you have to take note as well is that as you grow older, kamong mga bata mo, young pa man mo, okay? Pero wag niyo abusuin yung sarili niyo, yung youth niyo. Okay? Ayusin yung decision niyo sa buhay. If you are getting older, what happens there is nag-decline yung ating thirst regulation. So that is why yung mga older adults natin, they are at risk for what? Dehydration and hyperosmolality. That means that magiging mataas yung ating concentration. Okay? And of course, yung ating mga altered level of consciousness ng mga patients natin, of course, di ba, remember, if your level of consciousness is altered, bumababa yan siya. But that means that you become lethargic. Okay? May pakialam ka ba kung uhaw ka o hindi? Wala. Gusto mo lang matulog. Okay? Every day, matulog ka na lang. Ayan. So they are unable to respond to thirst. Example of this one, yung mga intubated natin na patients and artificially fed are at risk. Okay? Ayan. Next is for your kidneys. This is basically the primary responsible for regulating your fluid volume and electrolyte balance in the body. Paano? Let's start off with your, anong tawag dito? Fluid. Fluid muna tayo kasi iba itong electrolyte. Your fluid naman, if ever you are dehydrated, increase ang reabsorption ng ano? Reabsorption ng water. Okay? Para magkaroon, and then there will also be increased reabsorption of what solute kung dehydrated ka. Ano yung solute na promote ng water retention?
Sodium, sir.
Yes,
Sodium.
very
Sodium,
good.
sir.
Your sodium. Okay, kuha natin. And then here, pag electrolyte imbalance naman yan siya, of course, if your body is normal, of course, kung wala ka talagang sakit, even if may sakit ka, meron pa rin siyang ginagawa. It's just that it is not that effective compared to a person who is very healthy. Okay, let's say for example, if you have electrolyte imbalance, kung ano yung sobra, yun yung ini-excrete ng ating kidneys. Kung ano naman yung kulang, that is the electrolyte that is being reabsorbed by your kidneys or specifically doon sa ating renal tubules. Okay? And of course, you have there, this is not regulation of electrolytes, this is regulation of acid and base. Okay? Pag meron tayong acidosis class, if you have their acidosis, okay, what do you think will happen or what do you think will your kidneys do? Okay, it will now increase the regeneration of your bicarbonate. Okay, pag alkalosis naman yan siya, what do you think will happen? There will be decrease in the regeneration of your bicarbonate. So ito, andito pa rin yan siya, pero decrease yung regulation or regeneration niya, plus what? There will now be reabsorption of your hydrogen ions. Kuha natin. We will be discussing this one dun sa ating acid-base balance. But basically, this is how your kidney regulates yung acid-base natin. Pag acidosis, again, sir, tanong, ano na acidosis or alkalosis? This is basically respiratory. Okay? Kasi kung metabolic yan siya, what do you think is the problem pag metabolic acidosis or alkalosis? May problema tayo sa kidney. Okay? So in these cases, remember, if ever may problema sa kidney, your lungs will try to compensate. If may problema sa lungs, your kidneys will try to compensate. Kaya dito, you have the respiratory acidosis, ito yung gagawin ng kidney. You have the respiratory alkalosis, ito yung gagawin ng kidney natin. Kuha natin. Are there questions muna before we move on? Wala? Sige. Okay. Respiratory system, yung sabi ko sa inyo kanina, of course, you have there your lungs. Okay? Dalawa lang talaga yan sila sa acid-base balance ninyo. Okay? Tatlo actually ang nag-regulate. You have there your buffer system ninyo, which neutralizes yung acid natin, yung weak acids natin. Pag hindi yan siya, or if ever your buffer system does not work to correct your blood pH, dito napapasok either your lungs or your kidneys. Kuha natin. Kasi tatlo yun sila. Yung buffer system natin, you have there your lungs, and of course your kidneys. Now sa lungs natin, this is basically excreting moisture during exhalation. Okay? Balik tayo sa fluid regulation. Ito yung sa fluid regulation. Ito yung ginagawa ng ating lungs for fluid regulation. Excreting moisture during exhalation. Again, ano yung sabi ko, whenever you are exhaling air, may kasama po yan na tubig. That is what we call your insensible water loss. Okay? So if ever, pansinin niyo, if ever you are bloated, no? Kung bloated ka most of the time, anong tawag ito? That is fluid volume excess ka dyan. Okay? Anong napapansin nyo? Mas mabilis kayong huminga. Okay? Question dito, what increases, aside yung sa sinabi ko what increases the excretion of moisture through the lungs? Anyone?
Sweat.
Sweat. If you're sweating, what are you doing? Ang dami mong ginagawa pag magsasweat ka, di ba? Exercise. So that's number one. If you're exercising class, or if you are involving yourself in your physical activities or your daily physical activities or physical exercise, ayan, tumataas yung excretion of moisture kasi tumataas din yung paghinga natin. Okay? Mga activities na yan. So your lungs regulate acid-base balance. O ito, tatanungin ko kayo, paano siya mag-regulate? Oxygenation ninyo. How does it regulate acid-base balance? Kung meron tayong metabolic acidosis, anong ginagawa ng ito dito, alkalosis? Anong ginagawa ng lungs natin pag acidosis? Let me rephrase para ma-review yung utak ninyo. Yung blood pH natin or yung ating ABG reading, ano ba yung kasali doon? You have there your pH. Ano pa?
Bicarbonate.
Yes, you also have there your bicarbonate. Ano pa?
CO2, sir.
Very good. Your CO2 or your PCO2 or your PaCO2. No, pareho na sila ang PCO2, PaCO2. That depends on the author of the book. Okay, ngayon, question. Meron na tayo dito Meron na tayong tatlo. Okay. Which do you think can your lungs regulate dito?
CO2, sir.
Very good. It is your CO2 or your PaCO2. Ngayon, pag acidosis yan siya, what do you think will happen? Okay? Pag acidosis yan siya, di ba dapat there will be an increase in the release of your CO2. Increase excretion through exhalation of your CO2. Kuha natin. Pag alkalosis naman, what do you think will happen? There will be decreased excretion or magkakaroon ng conservation of your carbon dioxide. No? I-erase ko muna itong decrease. Kasi malibog mo. There will be a conservation of your carbon dioxide. Okay? Ayan. So, hyperventilation. Hyperventilation tayo. Kung nagha-hyperventilate ka, that is a way of compensating Saan ba dito? Ano mangyayari pag magha-hyperventilate ka?
Taas ang need sa, sir?
Saan sa man? Ang tanong.
Oxygen.
mataas, not really the need for the oxygen, pero anong tawag ito? Pag nagha-hyperventilate ka, anong nangyari? Acidosis or alkalosis? Pag na-hyperventilate ka.
Acidosis.
Is it acidosis? Alkalosis siya. Okay? Ang magbi-build up kasi ngayon ang oxygen, ang oxygen ninyo, tapos yung ratio niya is mababa yung sa carbon dioxide. So pag meron kang anong tawag ito, acidosis, okay, a compensatory mechanism for that one is your what? Hyperventilation. Okay, analyze nyo lang talaga. Because when we're talking about hyperventilation, karami ito anxious ka. But the example of being anxious, that is not a compensatory mechanism. Okay, kasi of course that is your response to another stimulus. Let's say for example, namatayan kag iro or nawad-an kag uyab, okay, or wala kay makaon. Hilak na jud ka, no? Tapos mag-hyperventilate ka. Ana. So what happens there is that, anong nangyayari sa inyo? You might feel ninyo nahihilo kayo. So ano yung ating nursing intervention for that one to correct your hyperventilation that is caused by your anxiety?
Drink,
Keep breathing,
drink
sir.
water, sir.
Drink water. Sige, pakalmahin. Yung number one talaga is that you need to treat the cause of the anxiety. Pakalmahin mo yung patient mo. Okay, pakalmahin or kung sino man yung nag-hyperventilate. That's number one. Okay, treat the anxiety or the cause of the anxiety. What is next? Ano pang iba?
Deep breathing, sir.
Deep
Sir, katong
breathing.
may nga sa bag, sir.
Yes,
Ay.
unsa nga bag? Unsa man to nga bag? Miss Ontua.
Paper bag, sir. Paper bag, sir.
Yes,
Paper
paper bag or your brown bag. Okay? So pwede yun siya, no? So you have there treat the anxiety, pakalmahin natin. Ano nga yung isa na answer? Nakalimutan ko. Aside sa deep breathing, yes, yung deep breathing natin. Okay, normalize natin ang breathing. And next is yung ating paper bag, no, para mag-circulate lang yung carbon dioxide natin. Okay, paper bag or your cupped hands. Ano mag-anak ko? Kung wala kang paper bag, so pwede yung kamay mo, ganun mo lang. Tapos maghinga ka. Okay? So that is yung ating hyperventilation caused by your anxiety. But there are times wherein nag-hyperventilate yung ating or hyperventilation, meron din tayong tinatawag na Kussmaul's respiration. Okay. Itong Kussmaul's respiration, meron na talagang sakit. No? Meron na talagang sakit yung patient natin. So your Kussmaul's respiration, mabilis ang paghinga niya. There's hyperventilation as well. Okay? Para ma-excrete yung ating carbon dioxide. Okay? Kung dito naman, in some books, they don't consider hypoventilation as a compensatory mechanism. Merong argument kasi yan eh. But if you get the point here, okay, pwede yan siya mag-hypoventilate yung ating lungs, no, to conserve your carbon dioxide. Kuha natin. So, it will now treat your metabolic acidosis and alkalosis. Kuha natin. That's how your lungs will try to compensate for that one and to regulate yung ating acid and base balance. For fluid regulation naman, increase or decrease RR lang tayo dyan. Okay? Pag mabilis ang respiration mo, that means that there is an increase in what? Insensible water loss. Insensible water loss. Pag dito naman, decrease ang water loss natin. Okay? Kuha natin. Ayan. Next, yung RAAS natin or your renin-angiotensin-aldosterone system helps maintain in the intravascular fluid balance and blood pressure because of your what? Angiotensin. Angiotensin. Anong angiotensin? 1 or 2?
1.
1,
2, sir.
2. You have their angiotensin. Kuha na noon na shortcut. Angiotensin 2, and you also have there your aldosterone. Okay? Ito talaga yung main component niyan. Yes, meron tayong mga pabida-bida at first eh. Meron yung mga pabida-bida and I will be explaining that one to you later or after this slide. Pero question muna, let's answer this one muna. RAAS yan na, sorry, RAAS, sorry. Okay. How is it activated or what stimulates your RAAS? Paano ba yung sisipa yung RAAS sa inyong katawan? Ano yung stimulus? Si Mr. Pereda, I think meron kang problema sa iyong audio. I'm sorry, sa iyong mic. Okay, kaya parang putol-putol eh. If you're trying to answer the question, no, or choppy siya. Okay, na yung mga feedback. Aside kay Mr. Pereda, meron ba nag-chat? Tingnan natin.
Pag nag-drop
Pag
yung blood
decrease
pressure,
ang
sir.
ano sir, blood volume.
Yes, sabi ni Mr. Pereda, pagbaba ang blood volume, pagbaba ang blood pressure. Yes, no? And those who stated
Perfect.
it as well, no? Perfect, perfect. Okay, so you have there, wait lang. Yung nag-stimulate niyan, decrease blood pressure. Kasi pag decrease ang blood pressure mo, the cause or the etiology of that one is decrease ang blood volume. It follows naman din kasi. No? It follows that if you have decreased blood volume, di-decrease din yung blood pressure mo. Pag decrease ang blood volume and decrease yung blood pressure mo, what do you think will happen? Hypoxia. Okay? So itong tatlo, it will just revolve around no, to stimulate your RAAS to happen or to kick in. Kuha natin, decreased BP, decreased blood volume, hypoxia. Okay? In some books, ito no, hypoxia talaga yung main na nagsistimulate. Okay? Ano yung isa ibang books din, yung blood volume natin. Kuha natin. Now, how are we going? Ito yung stimulus natin eh. No? Meron na tayong problema. Meron na tayong hypotension, meron na tayong hypovolemia, and meron tayong hypoxia. What is hypoxia again? Decrease
Oxygen level, sir.
Oxygen
okay.
level.
Decrease oxygen distribution. Distribution to your tissues. No? Distribution to your tissues. Kuha natin. Ayan. Okay. Did I already tell you the difference between hypoxemia and hypoxia? Naingon na ba na ako na? Yun na lang kung yes niya, din niyo ma-remember, okay lang. Yes, na-discuss na mo sir, pero nakalimtan na mo. Na-discuss na ba na ako na?
Kalimot.
Okay. Nakalimot pero na-discuss na ba na ako na sa inyo diri sa concept? Oh, sige, butan na lang sa nato dira. Hypoxemia. Okay. Now remember that your hypoxemia can always lead to your hypoxia, but it does not mean that anong tawag ito? Your hypoxemia will always lead to your hypoxia. Okay? But it does not mean that if you have hypoxia, meron kang hypoxemia. No. Okay? Your hypoxia, remember yung hypoxia natin, that is basically the decreased oxygen distribution to your tissues. Okay? That is why yung sabi ko nga sa inyo, yung hypoxemia ninyo will always result into your hypoxia, but your hypoxia does not always result na hypoxemia yan siya, or hindi always cause ng hypoxia nyo ang hypoxemia. Okay? Ay, mali yata yun eh. Basta hypoxemia will always cause hypoxia ha. Ayan. So, paano ba yan siya? Now, when we're talking about hypoxemia, that means what? Decrease O2 levels. Saan? Sa ating blood. Okay? Emia means blood. Specifically yung sa ating RBC. Because that's the one that contains your oxygen eh. Specifically doon sa ating hemoglobin. Okay, your hemoglobin is the one that carries your oxygen and even your carbon dioxide. Magsiswitch lang yan sila doon. Okay, kuha natin. So your hypoxemia will always trigger hypoxia. Okay? Pero here, class, pag sinasabi natin hypoxia, class, kahit normal, pwede ba, sir, tanong, pwede ba magkaroon ng hypoxia kahit normal yung ating, kung kahit normal yung ating levels of oxygen sa blood? Yes or no?
Yes, sir.
Yes, of course, pwede. Paano? Or what are the causes of your hypoxia? Tapos normal lang yung ating levels of oxygen sa blood. You have there your occlusions. Ang tao nga na stroke, okay? What is stroke in medical terms? CVA or your cerebrovascular accident. MI, tao na stroke na MI. Anong problema nila doon? What do you think is the problem? Bakit nagkakaroon ng stroke or myocardial infarction?
May obstruction sa ano, sir.
Yes, exactly. Hindi na nakakarating doon yung oxygen levels sa heart. May problema ba tayo sa dugo? Wala. Normal ba ang kuan? Ang O2 levels sa blood? Pwede or possible na normal lang yan siya. But because of your occlusion, hindi na yan siya nagkakaroon ng proper tissue perfusion. May it be doon sa utak mo or doon sa puso mo. Okay, so you have there your occlusions and you also have their problems sa ating brain problems. Okay, it does not necessarily mean that may problema ka sa oxygen levels sa iyong dugo tapos magkakaroon ka ng hypoxia. Okay, so kung meron kang problema sa breathing mo, of course it will also lead to your hypoxia and hypoxemia. Kuha natin. So again, your hypoxemia will always lead to your hypoxia, but you can always have hypoxia without having hypoxemia. Ayan. Raas. So let's now go to your raas tayo, class. Okay, raas. You already have here your decreased BP, decreased blood volume, hypoxia as your stimuli. Okay, so all of this will stimulate the release of what? You have there your liver, and you also have there your kidney. Ikuha natin. Your liver will what? Release your angiotensinogen. So, angiotensinogen. While your kidney will release what?
Renin, sir.
Very
Renin.
good. Renin. Okay? Ayan. Sir, paano ba ito sila mag-meet? Lalango yan sila. Humoral response ito siya, class. Diba? Remember pag sinasabing humoral, magsisecrete ng, again, lahat ito, class, lahat ng ito, renin, angiotensin, lahat ito hormones, they are made up of proteins as well. Okay? Lahat ng hormones niyo, they are made up of proteins. Okay, anyways, going back, pag humoral yan siya, they will be secreted doon sa inyo, papunta sa inyong bloodstream. Okay, they will be meeting with each other. Pag mag-meet yan sila, magkakainlaban yan sila. Okay, so they will bind with each other kasi nga nag-meet sa bloodstream ninyo eh. So once they bind with each other, what do you think will form?
Angiotensin 1, sir.
Very good. You have there your angiotensin 1. Sir, tanong, pwede na ba ito maka-increase ng blood pressure natin and pwede na ba ito maka-promote ng ating water retention? Yes or no?
No.
No, sir.
No. Impotent. Impotent mo rin naman. This is not yet the potent. No? Hindi pa ito yung potent. So itong angiotensin mo, once, of course, the product of binding your angiotensinogen and your renin, lalangoy pa rin siya sa bloodstream ninyo until it reaches your, ano man ito, class?
Lungs.
Yes, exactly. Yung 3 lobes. No? At least nakuha ninyong lungs ni siya. Okay. Now, doon sa lungs, that is where you will find your, what do you call that one?
Angiotensin converting enzyme.
Very good. Your ACE. Kaya nga, class, if we apply, kung mga, di ba remember your RAAS, it will correct your blood pressure. Pinapataas niya ito. Now, there are times where in your essential hypertension or in your primary hypertension, may problema tayo doon sa ating blood pressure because meron tayong tissue resistance eh. Okay? So, pirmi lang na mag-kick in ang atong RAAS. Pirmi lang na siya mag-kick in. That's why binibigyan one of the drugs or classification of drugs, yung mga antihypertensive drugs natin is what? Anong tawag doon? Your ACE?
Inhibitor.
Very good. Binibigyan yung ACE inhibitors para hanggang dito lang yan siya. Hanggang angiotensin 1 lang talaga yan siya. Okay? And diba, remember in your hypertension, okay? Doon, yun yung cause talaga, one of the many cause talaga or the main cause kung bakit napapagod yung heart natin. Because remember, pag mataas yung blood pressure natin, mataas yung arterial pressure natin, that means that it will now give rise, no, para sabihan yung heart mo, hoy heart, ayusin mo yung pag-pump ng blood. It's because of the fact that if ever the heart cannot overcome yung taas ng blood pressure mo, eh hindi talaga magpa-pump niya ng blood. Okay, babalik at babalik lang yun doon sa heart. That is why chronic hypertension would lead to what? Congestive heart failure. Napapagod din yung puso natin. Kaya ingat-ingatan natin yung puso natin para hindi mapagod. Kasi kahit anong hirap, no, kahit anong hirap ng ating katawan, class, no, your heart will always compensate for that one. Wag natin pagurin yung heart natin. Anyways, going back, nagdi-derail na tayo. Angiotensin converting enzyme, once it binds with your angiotensin 1, it will now convert. Kasi from the word itself, angiotensin converting. So, you will now have your angiotensin 2. Is this potent enough already to increase your blood pressure? Yes. Remember, lahat ito sila hormones, di ba? And when we're talking about hormones, meron yan silang target organs. Okay? Your angiotensin 2 can work or targets your blood vessels and will target your kidneys as well. Specifically, yung ating adrenal glands. Okay? Adrenal glands. Sir, saan ba yung adrenal glands makikita? Kana bitong katong murag kung mo ni inyong kidney. Okay, naadere. Okay, mo na sa inyong adrenal gland. Okay, adrenal glands. Okay? And to be more specific, your adrenal cortex. Okay? So it will now target the two. So punta tayo sa blood vessel muna. Once your angiotensin acts or targets your blood vessel, what do you think will happen with the blood vessel? Vasoconstriction or vasodilation?
Vasoconstriction.
Okay, very good. You have your vasoconstriction. Question, anong ginagawa ng vasoconstriction? Does it increase your BP? Yes or no?
Yes.
Yes,
Yes,
sir.
sir.
Increase BP. Now, did it address our problem here? Yes, it addressed the problem there. No, increase BP na yan siya. So increase BP, pag mag-increase ang BP, mas mabilis dadalo yung ating dugo. Of course, with the compensation din ng heart natin pag mas i-increase niya yung myocardial contraction niya. Okay? So mag-increase ang BP, it will now also address yung hypoxia natin. Kuha natin. Now, how is it blood volume pala itong isa. Sorry. Okay? Now, for the kidneys, your angiotensin 2 will work on the kidneys, specifically sa ating adrenal cortex that will now secrete your aldosterone. Again, your aldosterone is a hormone. Saan yan siya mag-act? It will now act on your renal tubules. Okay. Anong gagawin niya sa renal tubules? There will now be an increased reabsorption. Okay. Kwan shortcut ko na lang, reabsorption yan siya, reabsorption of your sodium. But what you also have to remember about aldosterone, aside from reabsorbing the sodium, what other electrolyte will it excrete? Or there is higher chance of, not really higher chance, no? Mas mabilis ang pag-excrete niya ng anong electrolyte?
Potassium, sir.
Very good. It is your potassium. Kaya class, meron tayong, we have to decrease ang potassium kasi decrease, bakit decrease ang potassium? Because there is an increased excretion of your potassium. Kuha natin, so magkakaroon ng hypokalemia yan. Pag of course, chronic naman yan siya. Okay, so that is basically your RAAS kung bakit. Now, increase sodium reabsorption, that means that there will be, okay, there will be water retention. Question, did it address now the problem of your decreased blood volume? Yes. If there is water retention, then there will be increase in your blood volume. Okay? Pag nagkakaroon ka ng hemorrhagic shock, nagraraas tayo. Okay? Pero again, pag mabilis masyado talaga yung bleeding natin, kaya nga we have to do medical management. For that one, you're going to give blood transfusion and your normal saline solution, no, para mag-increase yung ating intravascular or para mag-increase yung ating blood volume kasi mga volume expanders man ito. Kuha natin. Ayan. And let me just add na lang, no, kasi I think nakalimutan ko ito kanina. Add ko lang. Okay. Remember yung BT natin, no, to address yung hemorrhagic shock. Remember, for your BT, the patient will be at risk for kung multiple blood transfusion. Okay? Hyperkalemia. And you also have their hyperphosphatemia. Hyperphosphatemia. Lakas kay murag. Dara. Okay, going back. Okay. So at risk yan sila klasa, your patient who is having multiple blood transfusion, magkakaroon yan siya ng hyperkalemia. Okay? Or at risk for hyperkalemia and hyperphosphatemia. Bakit? Remember, you have there your red blood cell. Okay? RBC tayo. Okay? Can you still remember your piso and pico? Ma-remember nyo pa ba yun? Piso pati pico ninyo?
Yes, sir.
Okay.
Yes, sir.
Okay. So basically, both of these electrolytes, potassium, and you also have there your phosphate. So kani ang kuan sa phosphate.
Yes, sir.
P lang ba yun yung phosphate? Kalimut ko,
Yes.
sorry. Phosphate. Ano na lang. Okay. Or PO4, I think, no? If I'm not mistaken, yung phosphate niyo. Anyway, basta phosphate yan sa class. Phosphate yan sa class. Ha? And you also have there your calcium. Okay. Now remember that both of these are what? Cations and anions inside the cell. Oy, Miss Optana, palihog kog mute din kay. Yan, sige. Now remember that both your calcium and your phosphate, they are found inside the cell, di ba? Now yung RBC natin, that is a cell, pero it is not considered as a true cell kasi nga wala siyang nucleus. Anyways, both your potassium and your phosphate are found inside your RBC. Now pag multiple kasi yan, kahit na nasa labas yung ating blood product, okay, nagkakaroon ng hemolysis yung ating red blood cells. When we say hemolysis, there's a breakdown. May namamatay. That's the reason why, class, na 4 hours talaga. Make sure that you infuse your blood transfusion or your packed RBC or your whole blood, no, within 4 hours lang talaga. Because pag mas mataas pa talaga or if ever you're going to extend that one, you are now increasing the risk of hyperkalemia and hyperphosphatemia. Phosphatemia doon sa ating patient. Bakit? Because it will now increase in the hemolysis of your red blood cells. So pag maghihemolyze yung ating red blood cells, the potassium and the phosphate will what? Will escape from the cell and andito lang yan siya sa labas sa inyong extracellular fluid. Okay, kay apil man po na siyang plasma dira. Okay? Mao na pag transfuse pa lang nimo daan, if ever dugay jud na siya nimo transfuse or more than 4 hours na siya naga-transfuse, daghang nangamatay dira ng mga red blood cells. Kuha natin, they are at risk for your hyperkalemia and hyperphosphatemia. Okay? I-add nyo lang doon sa sa BT ninyo class doon sa taas. Pinakauna. Okay? So are there any questions for your RAAS? Kuha ang RAAS? Yes, kuha,
Yes,
sir.
sir.
Sige. ADH tayo or your antidiuretic hormone. What is the other name for that one? Vasopressin. Okay? Released by your posterior pituitary gland. Okay? Meron din tayong imbalance of this. You have your hypo, kasi again, this is your hormone. Hyposecretion. And you also have there your hyper secretion. Meron yan siya mga terms class. I will be discussing that one later. Pero focus muna tayo dito. It is released by your posterior pituitary gland and then of course it regulates water excretion from the kidneys. Paano? Ano bang ginagawa ng antidiuretic hormone natin? From the word itself, antidiuretic, dili siya gusto nga mag-ihi-ihi ka. Though there are still or though you can still or meron pa rin ikaw maihi pero kokonti na lang. And they are more concentrated. No, yung ihi ninyo mas nagiging concentrated because it is what? Conserving your water. There will now be an increase in water or fluid reabsorption. Okay? Meron pa rin yan siya, you can still excrete yung sodium natin. Okay? Pero the main point here is that your antidiuretic hormone is that it promotes water reabsorption. Pwede ka pa rin umihi, ha? It does not mean that pag there is secretion of your antidiuretic hormone, hindi ka na nakakaihi. No. Okay? So, pwede ka pa rin umihi dyan. Pero, your urine output, if ever this kicks in, decrease ang urine output mo. Kuha natin because your body is now, or yung kidneys, kasi it will act on your kidneys, so there will now be reabsorption of your water. Kuha natin. So what is the stimulus to activate your ADH? Of course, dehydration. Okay? Or fluid volume deficit. Normally, ito yung inyong normally in a normal person, dehydration or fluid volume deficit tayo. Okay? Your dehydration can basically lead to your fluid volume deficit naman din eh. Kuha natin. Now, let's talk about the imbalance of your ADH. Now, for the imbalance, yung sabi ko sa inyo, hyposecretion and hypersecretion tayo. Okay? For your hypersecretion, sorry. Hypersecretion. Okay, you have here your hyposecretion. Okay? Who has any idea anong tawag doon sa hypersecretion natin? It is your SIAD. Okay? SIAD means S-I-A ni siya ha. SIAD, S-I-A-D-H. And your hyposecretion is called your DI. Okay? Your SIAD means what? Syndrome of inappropriate diuretic hormone secretion. Huwag natin kalimutan yung word na secretion. Okay? That means that, again, everybody say syndrome of inappropriate diuretic, anti-diuretic hormone. Para hindi makalimutan, sabihin, lahat-lahat.
Syndrome, inappropriate,
Oh,
secretion of antidiuretic hormone, sir.
pwede yun siya, no? Syndrome of inappropriate secretion of antidiuretic hormone or syndrome of inappropriate antidiuretic hormone secretion. No, any of the two, pwede rin yun siya. Etong DI, anong meaning ng DI? Dance instructor. Corny mo, sir. Ang corny. Ano ang meaning ng DI? Anyone? It is your diabetes insipidus. Okay? Sir, does it have something to do with your diabetes nga katong DM type 1, type 2? No, it does not have. Okay? Kaya siya tinawag diabetes, it's because it mimics the anong tawag ito? It mimics the 2Ps of your diabetes mellitus. Okay? You have there your polydipsia and your polyuria. Remember, this is hyposecretion of your ADH, ha? And this is the hypersecretion of your ADH. Sir, tanong, bakit nagkakaroon ng hypersecretion? Tumor. Okay? May times na idiopathic yan siya, pero pag magkakaroon ng tumor, yung ating posterior pituitary gland, ayan, you could expect hypersecretion of that one. Okay? Or even hyposecretion. Okay? Now, punta muna tayo sa ating hypersecretion of your antidiuretic hormone. There are three features. There are three key features for both your hyper and hyposecretion. Number one is you have here your hemodilution. Okay. Number two is your hypernatremia. Ay, sorry, dili na siya hyper. Hypo na siya, class. Sorry. My bad. Hypo. Ano naman siya? Hyponatremia. And lastly, you have there your urine concentration. Okay, let's discuss one. Pag sinasabi natin hemodilution, what do you think will happen? Remember, this is now the hypersecretion of antidiuretic hormone. What do you think will happen? Increase, no? Nagkakaroon ng hemodilution because there's an increased water retention. Abnormally, no? Water retention. Okay, so from the word itself, nadidilute. Now remember that when your water is being conserved, yung water mo serves as a solvent. Okay, so nagkakaroon ng water retention, there will now become or there will be hemodilution. Sir, tanong, bakit nagkakaroon ng hyponatremia? Who can answer? Your hyponatremia is not due to your deficit. Wala tayong problema sa kuan sa sodium levels dito. No, it's not the problem. That is not the problem. The problem is yung ating hemodilution. So your hyponatremia is due to your hemodilution. Nadidilute yung ating sodium because remember your sodium is the solute while your water is the solvent. Okay? Kuha natin, class. So nagkakaroon ng hyponatremia not because kulang tayo sa sodium levels, but because of your hemodilution. Urine concentration, bakit nagkakaroon ng urine concentration? Bakit nagkakaroon ng urine concentration? It's because of the fact that, remember, gina-conserve niya ang water, but it does not mean, katulad ng yung sabi ko kanina sa ADH ninyo, it does not mean nga dili mo makaihi. So your urine concentration is high, or there is urine concentration because of the excretion of your solutes. Okay? Tapos less yung ating water or your solvent. Sir, bakit ko konti lang yung water natin? Is again, yung water yung kanyang gina-conserve class. No, dili niya. So there will be an increased reabsorption of your water. What happens to your specific gravity?
Taas, sir.
Very good. Magtaas yung ating specific gravity. Okay? Let's talk about hemodilution. What happens to your hematocrit? Taas, baba? Diluted ni siya, ha?
Baba, sir.
Exactly. Okay? So the relationship of your hematocrit and your specific gravity, it is inversely proportional. Okay? Sir, tanong, ano ba tong hematocrit na to? Basically, your hematocrit is the one that is, yan yun siya yung lab test niyo na nagmo-monitor ng volume ng yung red blood cells and yung plasma ninyo, no, yung blood ninyo as a whole. Okay? So if there is hemodilution, that means that what? Hindi masyado concentrated. So that means that your hematocrit is decreased. Now let's go to your hyposecretion of your ADH, which is your diabetes mellitus. Mayroong tatlo pa rin yan siya. Dito, instead of hemodilution, this is the complete opposite now of your hypersecretion. Okay? Kung merong hemodilution, dito magkakaroon ng hemoconcentration. Okay? Bakit? Anong problema dito? It's because yung ating fluid level or yung ating plasma ngayon is mababa yung ating water sa plasma. Because remember, the composition of your plasma is 90% or 90+% of water. So magkakaroon tayo ng hemoconcentration. What happens to your hematocrit? Mataas. Okay? Number 2, ano ang opposite ng hyponatremia mo? Dito meron tayong hypernatremia. Sir, bakit nagkakaroon ng hypernatremia? Sige siya, ihi ng ihi ng ihi. Guys, ang iniihi dito is yung water alone lang. The body, another explanation for this one is that since the body perceives, uy, sige siya ihi. Let's try to help that one by conserving or by reabsorbing your sodium. Okay? Kaya magkakaroon na yun siya ng hypernatremia. Okay? Number 3, if you have your urine concentration, meron tayong urine dilution. Double L bang dilution class? L1L lang siguro, no? Dilution. Okay? So for your urine dilution, nadidilute. Okay? Nadidilute yung ating urine because nga increase ang output natin and the composition of your urine is more of your water or your fluid. Kuha natin. So dito, gina-conserve niya ang water pero there is still secretion or excretion of your urine pero mas mataas yung ating solute levels. Dito naman sa ating hyposecretion, okay, there is more conservation of your solute levels compared to your fluid. Kaya what do you think will happen to your specific gravity? Urine specific gravity, bababa yan siya. Okay, kuha natin. Now, question, may mga questions sa board exams, ano ba yung ating laboratory results or what diagnostic examination that will tell you kung meron tayong SIAD or meron tayong DI or diabetes insipidus. Basically, it's your hematocrit and your specific gravity of your urine. Okay, hematocrit and specific gravity lang yan. Kuha natin. Ayan, that is already enough. Questions doon sa ating ADH? Break muna tayo, class. Sige. Break tayo. Break tayo 25 minutes lang kasi para matapos na tayo kaagad. Konti na lang talaga. So we be back at sa aking watch, it's 5:55. Balik kayo 5:30. Okay, sige. Okay, and you're still back with your host. Charot. Okay, so let us unta na gamit ninyo ang time for recharging yourself. Okay. Banat na punta, class, banat na punta. Saan na ba ta? Okay, ayan. Can you see the PowerPoint being shared on your screen?
Yes, sir.
Sige. Let's talk about your ANP. Your ANP, by the way, si Mr. Maestrado ba tong nadaog sa kuan? Contest ba to last time? Mr. Maestrado, andyan ka ba?
Dili siya 3G, sir.
Okay, okay.
3H. Sir.
Sige, sige. But I think siya tong nadaog ato eh. Itong kuan. Itong may event tong SPC. Sige. Anyways, going back, ANP means atrial natriuretic hormone. Okay. Ito yung, let's just, peptide pala, peptide. Pero it's still a hormone. No? Peptide. Ayan. Atrial natriuretic hormone or peptide. No? Pwede na siya ANH, pwede mo siya ANP. No? Again, that depends on the author of the book. Okay, now ito siya, when we're talking about the ANP, ito yung parang kaibigan ng heart natin para hindi mapagod. No? Whenever your RAAS kicks in, ito siya yung tumutulong para pakalmahin or para to counteract your RAAS. Remember your RAAS, basically what? Ang end product ng RAAS nyo is increased BP. Increased BP, you also have the increased blood volume. Okay, and then it address your hypoxia. Now, dito nagfo-focus yung ANP ninyo sa increased BP or hypertension. Okay, this is the hormone released by your atrial muscles of the heart. Okay, and what stimulates it? Ito na po, yung BP natin. Okay, so ganito po yung explanation ng ating ANP. If there is increased blood volume or increased BP, ayan, the atrial will stretch and of course, there will be a release of your ANP. Dito na tayo. Okay? So this is your stimulus, yung blood volume and yung blood pressure ninyo. Now for your ANP, marami siyang target. Okay? First is that it will target your hypothalamus. Now it inhibits your vasopressin because doon makikita yung ating posterior pituitary gland. No? So your hypothalamus will send signals doon sa ating posterior pituitary gland. Not sasabihin na, hoy, stop ka muna, release ng vasopressin. Remember, your vasopressin is your ADH, antidiuretic hormone. And the output or the result of that one is, of course, sodium and water excretion. Okay, remember, ito po yung problema natin. Blood volume, increase in blood volume, thus there will be an increase in your blood pressure as well. Once this one is inhibited, yung ating ADH, so there will now be an excretion or increased excretion of your sodium and your water, thus addressing yung ating blood volume and yung ating increased blood pressure. Okay, next is that it acts on the kidney. It will now increase the glomerular filtration rate and it will always yun na automatic. Pag mataas yung ating glomerular filtration rate, taas ang atong urine output, ana. Okay, and of course it counteracts nga yung RAAS natin, decrease ang renin secretion. Thus, doon pa lang banda sa first phase ng ating activation of your RAAS, mai-impede na siya or there will now be a magiging hesitant na ngayon yung renin mo na lumabas kasi decrease na yun siya eh. Okay? So there will now be same pa rin. Okay? Adrenal cortex natin inhibits your aldosterone. Di ba remember sabi ko sa inyo kanina, your kidney secretes your aldosterone, specifically your adrenal glands, specifically your adrenal cortex. Okay? Your adrenal cortex, remember, aside from your aldosterone, it also secretes your cortisol. No? Pag-uusapan natin yan mamaya si cortisol. Another name for your aldosterone is your mineralocorticoids. Mineralocorticoids. Okay? And another term for your cortisol, glucocorticoid. Okay? Glucocorticoid. Okay, muna siya mga laing pangalan so that if ever makita, hala, di ba cortisol man to? And then you saw glucocorticoid, that is still the same. Okay, so it inhibits aldosterone. So pag walang aldosterone, it will not act on your renal tubules to increase the reabsorption of your sodium. So increase ang excretion pa rin and water. Okay, so walang water retention na mangyayari. And for your medulla oblongata, it will now decrease your blood pressure. Na-address ang BP natin, pag-increase ng BP natin. Okay? Kaya nga class, no, if ever na kay hypertension, somehow your ANP will kick in, no? Kaya nga chronic din yan siya eh. Okay, pag hindi ma-address talaga yung ating essential hypertension or your primary hypertension, okay, even your secondary hypertension, which is brought about by your other diseases such as your diabetes mellitus, magkakaroon ka talaga ng congestive heart failure dyan. Okay, mapapagod talaga yung heart natin. Kuha. So this is the one that regulates basically yung ating blood pressure, or pag meron tayong increased fluid volume, no? This will now address your fluid volume excess. Kuha natin. It does not address your fluid volume deficit, but instead it regulates or it addresses your fluid volume excess. Okay, kasi nga, if there's an excess in fluid volume, there is an increased blood volume, and of course, it will result into increased blood pressure. Ayan. Let's talk about your cortisol. Ano nga yung meaning or another name for your cortisol? It's your glucocorticoid. Okay? Another name for your cortisol as well, aside sa ating glucocorticoid, is your cortisone. Okay? Remember, cortisol, meron tayong gamot dyan. Okay? That is under your what? Yung ating anti-inflammatory drugs. Okay? Kasi diba there are two types of your anti-inflammatory drugs. You have there your NSAIDs, which is your non-steroidal anti-inflammatory drugs. Ito naman, it is part of your AIDs or your anti-inflammatory drugs. Okay, that is steroidal or yung SAIDs natin. Okay, steroidal yan siya, steroid. Okay, so for your cortisone, it is secreted by your adrenal glands. Again, to be more specific, it is your adrenal cortex. Okay, yung sa labas-labasan ng inyong adrenal gland. The function of this one is that it helps body respond to stress or danger, increases body's metabolism of glucose, controls blood pressure, and reduce inflammation. That's the reason why, class, no? Meron tayong tinatawag na stress eating. Okay? Pag stress ka, ito talaga eh. Ito yung, ang triggering factor niya is, or for your cortisol to be released is your stress. Okay? Sir, tanong. O ito, tatanungin ko kayo. O, ilabas nyo lahat ng stress ninyo. Ha? Wala akong pakialam kung sisigaw kayo or whatever. Okay, sabihin ninyo, what gives you stress ngayong at the moment? Sige, labasan tayo ng sama ng loob.
Question P.
Question P.
Research.
Research.
May kwarta.
Why kwarta? Sa pa.
Signal hinay.
Signal hinay. Okay. How about online class? Appeal jud na. I'm sure, appeal. Okay. Yung sa isang section, meron pa nagsabi uyab. So wala pala kayong problema sa uyab. Ay, gamhanan ng mga kwan, adunahan ng mga 3G na mga students, no? O 3H. Okay, ayan. So those are the reason bakit lumalabas itong cortisol. That's the reason din bakit yung nagsistress eating eh. Kasi there is an increased metabolism of glucose. Pag increase ang metabolism of glucose mo, there is a chance na mag-decrease or magkakaroon ka ng hypoglycemia. Kaya kain ka ng kain. Kaya tumataba tayo. Now, going back to yung sa ating drugs na cells or yung steroidal anti-inflammatory drugs ninyo. Remember, if you could still remember your pharmacology last year, okay? Last year of this semester din, okay? Pag sinasabi nating steroid therapy, okay? Steroids na ginagamit natin, ha? Example of that one is yung ating mga prednisone, mga corticosteroids na sila, okay? Or your corticosteroid therapy. Question. What are you going to look out for pag sa corticosteroid therapy? Or ano yung nare-remember ninyo pag meron tayong corticosteroid therapy? What do you remember about anything about your corticosteroid therapy? Yung mga effects niya. What you have to remember, number one, it should only be short-term. Short-term lang na siya. Nga naman, okay, ganito yung pagbigay, no? I was under steroid therapy as well because of my generalized inflammation, because this is an anti-inflammatory. This is being used to treat inflammation. Mas potent ito compared sa inyong kuan. Dili siya analgesic, anti-inflammatory lang siya. Okay, there's a big difference between that one, no? Pero kung ang cause ng pain niyo is yung inflammation, then basically it can also become indirectly as an analgesic. Kuha natin. So bakit short term lang ito siya? Because we are trying to prevent what you call your Cushing. Who can still remember yung naong sa Cushing syndrome or sa patient na merong Cushing? Are you still familiar with your kanam itong buffalo hump, truncal fat, kana, of course, buffalo hump, murag na ma-remember pa na ninyo.
Moon face, sir.
Yes, moon face. Yes, apil po na. Very good. No, apil na siya. Moon face, buffalo hump. You also have there your truncal fat. Tapos thin ang imuang upper and lower extremities. Okay? So they are trying to prevent yung Cushing syndrome natin. That's the reason why if you are or if the patient is undergoing corticosteroid therapy, you will expect the doctor to taper down. Okay, nagta-taper yung dose, taper the dose, nagta-taper yung dose natin. What do we mean by taper the dose? That means that let's say for example, usually mga 2 months manggod na siya. 2 months na siya ang therapy ana. So at first, this is just an example para malaman niyo kung ano yung meaning ng taper. So you have there 60 milligrams for the first 2 weeks, and then magbaba yan siya into 40 milligrams for the next 2 weeks na naman, and then magkakaroon ng 20 milligrams 2 weeks, and then lastly 10 milligrams for another 2 weeks. Okay, I'm not saying that this is the exact tapering down or tapering of your dosage. No, I'm just saying na pag mag-taper ka ng dose, pababa talaga yan siya until matapos mo yung 2 months mo na therapy. Kasi nga they are preventing your Cushing syndrome. That's the reason why short-term yan siya. Kuha natin. Another thing that you need to remember about corticosteroids, okay? Sa mga cancer patients natin or to any patient who is undergoing corticosteroids, anong mangyayari sa kanila? Magiging immunocompromised yan sila. Okay? Wait lang. Okay, immunocompromised. Okay, or immunocompromised. Okay, that means that they are at risk for or increase ang kanilang susceptibility. Pag sinasabi natin susceptibility, that you only use this word for infection. No, taas ang susceptibility niya for infection, may it be viral or bacterial. So mataas ang susceptibility to, of course, infections. Kuha natin. So ayan, yung cortisol natin. So hypersecretion of your cortisol, meron tayong tinatawag dyan. Okay, magkakaroon tayo ng Cushing's. Tapos kung decrease naman or hyposecretion of your cortisol, pag decrease, meron tayong Addison's disease. Okay, so ito yung ating Cushing's. As you can see, aside from that one, moon face. Yun talaga yun, moon face. Tapos buffalo hump. You also have there your truncal fat. Tapos manipis or maliit or payatot yung ating mga upper and lower extremities. Okay? Now, bakit nagkakaroon ng easily bruising? When we're talking about bruise, what is the medical term for bruising or bruise? Alam niyo yan?
Contusion, sir.
Ano yun? Ano yun, Mr. Pereda?
Contusion.
Contusion? Well, yes, your contusion can lead to that medical term, which is your hematoma. Okay? You have there your hematoma. Bunog ba? Bunog na. Okay? So you have there your hematoma or bruising kasi contusion, that is, nag-neuro na ba kayo? Next sem pa ata yun eh. Anyways, no? Okay? Another synonym for your bruising, no, is yung contusion ninyo. Okay? Kanang adjaring ba? Adjaring, nauyog. Okay? So you also have there your hematoma. Okay? For your lesion. Okay? So, bakit ba? It's because of the fact that if ever yung effect nito sa inyong katawan is that yung ating layers sa ating skin is nagiging manipis na yan siya. And if ever nagiging manipis na yan siya, they are prone to injury already. Kaya nagkakaroon ng bruising. Madali lang sila mabunog. Okay? So that is for your Cushing, and this is your Addison's disease. Now sa Addison's disease natin, magkakaroon tayo ng fluid volume deficit. Okay, for your adrenal crisis, you have there your profound fatigue. As you can see, if you're going to compare your Addison's to those persons na merong Cushing, mas mataba yung talaga, yung sa may Cushing. Dito kasi meron tayong hyposecretion of your cortisol. Kuha natin. So you have there your hypoglycemia, postural hypertension, weight loss as well, GI disturbances, weakness, change in the distribution of body hair and bronze pigmentation of the skin. And you also have this one for the adrenal crisis. Okay, so magkakaroon tayo ng fluid volume deficit kasi meron tayong dehydration, vascular collapse of your blood pressure. And then remember, di ba sabi ko sa inyo that your sodium and your potassium are inversely proportional talaga yan sila. Okay? Yan. And renal shutdown pa dyan. This is already yung adrenal crisis natin. That is basically the emergency situation already that is brought about by your Addison's disease. Okay, now let's go to your parathyroid hormone or your PTH. Okay, parathyroid hormone, which is being secreted by your parathyroid gland. Okay, that is located in your thyroid gland. Now, what you have to remember here as well, kasi lumalabas sa board exam din natin, is that if ever meron kang problema sa iyong, or meron kang hyperthyroidism brought about by tumors, kailangan talaga tanggalin. So, magkakaroon ng thyroidectomy. Now, during thyroidectomy, nasasali po pagtanggal yung ating parathyroid gland. And that's what you're going to monitor. You're going to monitor now the calcium levels. Kasi when we're talking about the parathyroid, it now addresses yung ating imbalances. No, imbalance in your calcium levels. Okay? In the blood. Kuha natin. Ayan. So this is the most important endocrine regulator of your calcium and your phosphorus concentration in your extracellular fluid. Okay? Paano ba yan siya ma-regulate? Okay? Paano ba yan siya, or what is the stimulus? Of course, dito tayo sa klase, focus on the lower end. Kasi pag merong decrease, magkakaroon tayo ng hypocalcemia. Okay? So, ang kanyang triggering factor is the low calcium levels in the blood. That is the stimulus. Okay? Dili man guna siya your negative and your positive feedback mechanism will not initiate itself pag wala talagang stimulus. Okay? Pag walang stimuli. Okay? So, you have their falling blood calcium levels. What happens there is that it will now send signal to your parathyroid glands to secrete your parathyroid hormone, okay? Or your parathormone, okay? And then, ang target organ or target cells ng PTH ninyo are your osteoclasts. Question, are your osteoclasts bone destroying or bone forming?
Destroying, sir.
Very good. This is now bone destroying. Okay. One of the common mistakes of the students, no, malibog sila kasi it says there, or the name itself states na blast, no, tubuto, no. So kung sinasabi nating bone destroying, it is your class. Okay. So increase ang activity ng ating osteoclast. That means that there will be degrading bone matrix and release of blood, of calcium into the blood. Remember that this is your bone. Okay. Kung ito yung bone mo, remember that the extracellular matrix of your bone is your calcium salts. That means that kaya nga matigas yung bone natin is because of the calcium. Now, pag mababa yung ating calcium levels in the blood, there will be activation, no, yung mga activities ng ating osteoclast. Thus, it will release, no, magde-destroy yan siya dyan. Okay, releasing, in layman's term ba, bone destroying siya kasi it will now release yung stored calcium ninyo doon sa bones natin. This is, wag nyo naman masyadong literalihin. Do not take this one literally wherein ginasira niya talaga ang bone nyo. Okay, in a physiology, in a normal physiology. Normal na nga, physiology pa. Anyways, pag normal ka lang talaga na tao, there will be, anong tawag dito? Demineralization of your calcium. So lalabas yung calcium natin na store dito para magtaas yung ating calcium levels. Pero may times wherein due to compensatory mechanism, okay, your body keeps on telling you, uy, mababa talaga yung calcium mo, mababa talaga yung calcium mo. So this one here just keeps on repeating itself. Kaya nga yung may mga problems tayo doon sa ating kidney, okay, if you have their acute or maybe chronic kidney disease, no, they are prone to fractures. Bakit? Bakit? Okay. What vitamin, question ko sa inyo class, what vitamin regulates the absorption of your calcium? Anong vitamin yun?
D, sir.
Very good. It is your vitamin D. Okay? Your vitamin D comes from your, anong tawag dito? From your diet. No? Pwede man na siya makaon, gyapon, or there are some food that contains your vitamin D. And then meron din doon sa sun. But again, dili na siya gikan sa sun ang vitamin D, ha? It basically metabolizes once the UV rays or the UV light touches your skin, it promotes now the activation of your vitamin D. or the synthesis of your vitamin D. I'm sorry, not activation, but the synthesis of your vitamin D. Okay? Pero yung last stage talaga wherein there will be activation of your vitamin D para magamit natin yung vitamin D ninyo is sa kidney ninyo. Now, if may problema ang kidney ninyo, of course, there will walang magiging activated vitamin D. Kasi kahit na kumakain tayo ng mga food that is rich in vitamin D, hindi pa rin natin yung magagamit unless, of course, ma-activate ito or unless it will be transformed into your activated form. Okay, I think if I'm not mistaken, yung calciferol ninyo. Okay? So kung hindi yun siya kung hindi yun siya ma-activated, yung vitamin D mo, of course, it will not increase the absorption of your calcium. Thus, sige lang ni siya, cycle, until such time na grabe na ang demineralization ng inyong bones. That is why person or individuals with disease or chronic kidney disease or acute kidney, chronic siguro, no? Chronic, not the acute one. Okay? Chronic kidney disease kay magiging, CKD. Chronic kidney disease kay at risk yan sila for fractures. Kuha natin. So that is the role of your PTH. Pag mataas naman dito, hypercalcemia, okay, magkakaroon tayo ng stimulation of your thyroid gland to release your calcitonin or your calcitonin. And then this will now stimulate calcium deposition in the bone, which is being monitored or being controlled by your osteoblast. Kasi bone forming yun siya. Okay, so masastore yan siya dito. There will now be also increased absorption doon sa ating intestine, no, for your calcium. Okay, so yung activated vitamin D ninyo will act doon sa ating intestine, no? Doon siya mag-absorb ng calcium. And then magdi-diffuse na lang yan siya kaagad doon sa ating bones. Okay? Para ma-store. So for the fluid shifts, bakit meron tayong fluid shifts na dito? Okay, review na lang to. Okay? Osmotic pressure, pag mataas yung osmotic pressure natin, remember 'di ba yung sa ating example before, if you have here your water molecules, tapos meron ding water molecules dito of equal amount or of equal concentration, and then you're going to add solutes natin dyan, may it be sodium or glucose. What do you think will happen dito? Of course, lilipat yung ating mga water molecules dito, osmosis. So pag when we're talking about osmotic pressure, your osmotic pressure increases if ever mataas din yung ating solute concentration. Okay? Hydrostatic pressure, remember, it is being given or the one responsible for your hydrostatic pressure is your heart. Okay? Your oncotic pressure naman, same thought lang din siya sa osmotic pressure niyo. Okay? Here, albumin. Pwede rin gani dito albumin din eh. Okay? I don't know kung naduha ni siya dire. Okay? Yung protein natin, di ba? Okay, because your albumin or your protein increases din yung ating osmotic or oncotic pressure. Okay? So fluid shifts, plasma to interstitial. I think hanggang dito lang tayo eh. Your fluid shifts is from plasma to interstitial and from interstitial to plasma. Question. Okay, question. You have here two choices. Okay? Saan dito sa dalawa, this is A, this is B. Okay, pili lang kayo sa dalawa, no? Saan dito ang makalid ng congestion? Sorry.
B, sir.
Very good. It is your B. Saan dito yung edema?
A, sir.
Very good. So your A, yung plasma shift or yung fluid shift, kasi we're talking about fluid shifts. Yung plasma to interstitial, that would lead to your edema. Okay? And then your interstitial to plasma, that could lead to your congestion. Kuha natin. No? Ngayon lang na-remember pa ninyo ang plasma. No? Your plasma is part of your intravascular space or your intravascular fluid. One of the name of your plasma is your intravascular fluid. Meaning, andun siya sa loob ng blood vessel mo. Okay, very good. Edema and your congestion. So still the same explanation ko sa inyo before. No? Yung nagbuhat-buhat ko, I think, katong naki-blood vessel dire, and you have here your arteries and then your venules and then your capillaries. Tapos dito sa kabila, purple pag gani ito akong gidrawing. This is your veins. Okay? So kung may problema tayo talaga, kung if ever we're going, sir, bakit nagkakaroon ng edema? Okay, that will now give rise to decrease yung ating, ano man, hydrostatic pressure or your osmotic pressure. Asa man dito ang decrease? Bakit tayo nagkakaroon ng edema? Is it your osmotic pressure or your hydrostatic pressure? So this is your A, letter A, ito B, ito letter A din. Ano man?
Osmotic, sir.
Yes, osmotic. No? Decrease yung osmotic pressure. Di ba remember, sabi ko sa inyo class, that if this is your blood vessel, ito yung interstitial space niyo, ito yung mga tissues ninyo. Okay? For your fluids, di ba remember? Tapos ito yung ating, just think na dito banda, veins na ito siya, class of veins. Tapos ito arteries ito. And then you have there your arterioles. And then in between that is your capillaries. Di ba sabi ko sa inyo, because of the pumping action of your heart that will give the hydrostatic pressure, it will now push your fluids palabas sa inyong intravascular. Okay? Now, normally, if you have a good oncotic pressure, it will now pull back the fluids from your interstitial, di ba? So, kung mababa yung ating oncotic pressure or your colloid oncotic pressure or your osmotic pressure, magsistay lang talaga yan siya dito. Kaya nga binibigyan natin ng albumin, no, directly to the vein, or pwede din yung ating mga how do you call this, hypertonic solutions. Kuha natin para mag-increase yung oncotic pressure dito para ma-pull back yung mga fluids from the interstitial going back to your intravascular. And then pag may congestion, add ka lang ng diuretic. Kuha natin. Ayan. Pak. Ito. So, ito yun siya. Same picture pa rin. Same concept. Same meaning. Okay. So, ito yung sa kidneys natin. This is basically your, ano tawag mo dito? Itong parang yarn na ito. This is your capillary ito, di ba? What do you call that one? Glomerulus. Di ba, ingon ko sa inyo sa una, your glomerulus is a specialized capillary. Okay? That is specific to your nephrons. Ito yung Bowman's capsule natin. So from here, mafi-filter ninyo dito yung blood ninyo, specifically yung plasma. Your red blood cells will not cross your Bowman's capsule because it's too big. Even your proteins, no, they are too big to pass through, no, dito. Okay? So dapat talaga mas mataas yung ating blood hydrostatic pressure para ma-push talaga yung fluids from the intravascular going to your extravascular. Kasi ito siya, papunta na dito. Ito na yung mga renal tubules natin. This is your proximal, no? Proximal convoluted tubule. Tapos pupunta siya sa distal convoluted tubule. And then it will become your urine already. Okay? So meron pa rin mga pressure naman din na nag-act against your hydrostatic pressure. That is basically your blood colloid osmotic pressure. Pero dapat talaga mas mataas talaga yung blood hydrostatic para ma-filter talaga. This is basically the GFR ninyo dito glomerular filtration na ito dito. Itong pinapakita dito. Okay? Questions, clarifications? Uy, black na. Wala?
None, sir.
Okay. So just give me 10 minutes more para ma-start nato ng kuan. Okay. 3 slides na lang. So let's start off with your fluid shift. So, lecture pa jud ka, sir. Gamay na lang man eh. Okay. So ito, na-discuss ko na plasma to interstitial. That means that magkakaroon ka ng edema. Another term for your edema is your third space shifting. Okay? So palpable swelling produced by expansion of the interstitial fluid volume. Kasi nga, it's either weak din yung ating oncotic pressure. Okay? Para hindi na niya ma-pull back yung mga fluid. So nag-stay, there is a stasis of, or there is a buildup of fluid doon sa ating interstitial. Kaya nakakaroon tayo ng edema. Maybe localized or generalized. Yes, that's correct. When we're talking about localized, doon lang talaga siya sa isang area. Example of your localized edema, yung sa mga IVF infusion natin. IV infusions natin, Okay, yung mga infusions natin such as your infiltration. Okay? It is just located on your incision site or yung site of infusion ninyo. Okay? Another one, tissue injury. Nagkakaroon tayo ng localized, if there is, kanabitang masamad ka, there's tissue injury, di ba, magkakaroon ng vasodilation mo din yan, and there will be, or the permeability of your blood vessels will increase as well. So, there will be an escape, no? Magli-leak yung ating capillaries. Kaya yan merong swelling pag there is tissue injury or kung nasugatan ka. Okay, those are localized. Generalized naman, yung mga cases wherein, ano tawag ito, meron kang problema sa heart mo, okay? Kung right-sided heart failure, that means that you will be having edema sa ating upper and lower extremities. Okay? Ayan. Or kung left-sided naman, magkakaroon ng congestion doon sa ating pulmonary, doon sa ating lungs. Okay? Siya tanong, anong problema or what is the difference between your pitting and non-pitting edema? Diba? If you could still remember sa HA natin, assess the lower extremities for edema. You're going to start with morning tiil nimo. Okay, start ka dito sa baba. You're going to palpate that one, ana, and then paakyat ka dyan. Just to, bakit sir, bakit umaakyat pa tayo? You're going to check for the extent of your edema. Kung hanggang saan yung edema mo. Okay? Kung mas mataas yung edema, that means that there is really a problem with the congestion of your blood vessels. Okay, kung hanggang dito pa lang, then that means that it's not yet that worse. Pero it will just tell you that there is already a problem with the congestion of your blood vessels. Okay? Pero nagunan sa diliing ng congestion of the blood vessels. Congestion means sa blood vessel talaga yun siya. Okay? Pitting, non-pitting, anong difference? Anyone? Pitting. You have there two types of your edema, di ba? Pitting edema. And you also have there your non-pitting. Yung sa may difference, ana?
Mulubog ang pitting, sir.
Huwag mulubog. Oh.
Yes, very good. Sabay daw sila. Ay, dili sabay. Okay. So you have there yung pitting, okay, mulubog. Okay, that means that there will be dent, no? Kanang bitong pag-press nimo ana, dugay kayo na siya mobalik. That means yung grading, meron din kasi tayong grading ng edema natin eh. Okay, so i-grade mo din yun siya kung sa kadugay mo balik, no? Pero dugay yun kaya na siya mabalik. That is basically your pitting edema. Yung non-pitting natin pag-press mo niyan, okay, balik na po siya iyaha. Pas mo balik. But basically there is swelling talaga. Kuha natin. Okay, can cause fluid shifts and other vulnerable areas. This is termed as your third space shifts, yung ating edema. Same regular sila. Edema, third space shifts, it's the same. Okay? Pag sinasabing third space shift, it's edema. Pag sinasabing edema, it is basically your third space shifts. And where can your fluid shift? It could be, mali niya, dili ni siya open, close parenthesis, pwede sa plural space. Saan ba nakikita yung plural space? The plural space. Asa man na?
Sa lungs, sir.
Very good. Lungs. No? So plural cavity. Okay? Kanang plural space natin, another term for that one is your plural cavity sa lungs natin. Peritoneal space, asa man dapit?
Abdomen.
Very good. You have there your abdomen. Okay? Mauna siya, pag naatay peritoneal or fluid shifting, no, padulong sa inyong peritoneal space or peritoneal cavity, what do you call that one? Ascites. Ano din na masulat? It is your ascites. Okay? Ascites, basically, pwede yan sa liver problem. Most of the time, pag meron kang liver problem, magkakaroon ka ng ascites. Bakit tayo nagkakaroon ng liver problem? Kasi kitag inom. Ta, jud, no, ta. Damay-damay na ni. No? That is why, if you are a chronic alcoholic, no, expect na magkakaroon ka ng liver problems. Okay? Ayan, ascites. Kaya nga, binibigay albumin. Albumin, IV drip, or IV drip na siya, IV drip, or kanang bitong piggyback, no, side drip, albumin. And then, sir, tanong, ang diet ba sa, unsa man ang diet sa inyong patient na may liver problem? High protein or low protein diet?
Low protein.
Unsa man? Nay na nag-answer og low protein. How about for others? Nay mag-answer og high protein? Basically, pag meron kang liver problem or liver cirrhosis, it is low protein diet tayo, ha? Sir, bakit low protein na kailangan man natin ng albumin? Of course, may damage ka na dito sa liver mo. You already have a problem with your liver. Do you think your liver can still metabolize your proteins? Dili. No? Dili na siya mag-metabolize. So it will not help or it will not address the problem with your third space shifting. Okay? Low protein siya pero pwede pa rin siya bigyan ng albumin. IVTP sa veins natin. Okay? Ayan, major causes of edematous state, decreased colloid, ito, na-explain ko na ito. Okay, that is why there's no pulling back of fluids, di ba? Example, you have their burns and liver failure. Okay, increased capillary hydrostatic pressure. Example niyan is your congestive heart failure. Okay, increased capillary permeability, same pa rin, burns, allergic reaction as well. Kasi nga, bakit sa burns, okay? Kasi nga meron tayong tissue injury. Dito naman, kung sa decreased colloid osmotic pressure, there will be a release. Namamatay kasi yung cells or there is damage, no? Nagkakaroon ng lysis yung ating cells. No? Kaya nagkakaroon ng release, no? Na-release yung proteins inside the cell. Remember that daghang mga proteins kina-produce sa cells by our organelles, di ba? You have there your ribosomes, it synthesizes protein. You have there your, sa pa ba ito nag-synthesize? Your rough endoplasmic reticulum, it synthesizes your protein. Pag masira yan siya, labas lahat ang ating protein. Okay? And then you also have there your lymphatic obstruction or increased interstitial colloid osmotic pressure. No, doon sa interstitial nga, ang mas mataas na ngayon ang ating osmotic pressure. That is why the fluid will just stay doon sa yung interstitial. Okay? Ayan, ito nasabi ko na to, diuretic therapy. Yes, elevating the affected extremities. It's because of you are now decreasing the pressure. Etong tatlo class, you are now decreasing the pressure. Okay, ito naman, of course, diuretic therapy para mag-decrease yung ating edema. This is to decrease edema. Okay, ito to decrease the pressure para wala ding masyadong mag-leak doon sa ating mga capillaries. You elevate the affected extremities, you add pressure, no? Ginapaguot nimo ang isa ka butang para dili siya mag-leak. Okay? And of course, you have there your albumin para to increase the what? COP or your colloid oncotic pressure doon sa blood vessels natin. Kuha natin. Ayan. Done. Okay. Ayan. That's all.